Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. Today's topic is intestinal obstruction. We have seen in the previous classes that in many of the diseases of the small and large bowel, we find the bowel is obstructed. And that obstruction leads to a condition called the intestinal obstruction. What is the definition? Lack of transit of intestinal contents. By any cause, if the intestinal contents are not being propagated, it is called intestinal obstruction. It need not be something like a mechanical thing coming and blocking. It can be anything. If the intestinal contents are not able to be propagated, then we call it as the intestinal obstruction. So now let us see the causes for this obstruction. The classification according to pathology, anatomy, nature of presentation, and pathological changes in the bowels. Classification according to pathology. Dynamic. Dynamic means there is some movement. So where peristalsis is working against a mechanical obstruction. So dynamic obstruction means there is lack of transit of intestinal contents associated with vigorous peristaltic activity of the bowel. Why there is vigorous activity of the peristaltic? Why there is vigorous peristaltic activity of the bowel? Because there is something obstructing the pathway. To overcome this obstruction, the bowels are contracting vigorously. So this is dynamic obstruction. So dynamic obstruction, dynamic intestinal obstruction means it is a mechanical obstruction. Then the other thing is the adynamic obstruction. That means opposite. That means there is no movement. There is no movement of the bowel, and that is causing the obstruction. So why there is no movement? That means there is lack of peristalsis due to some cause. So if any cause produces lack of peristalsis, then there will be lack of transit of the contents. So that is also called as intestinal obstruction. So probably you may be under the impression that obstruction means something is blocking. That is why the intestinal contents are not being propagated. It is not like that. So if any lack of transit is there, then we should call it as intestinal obstruction. I hope this is clear to you now. So this can be due to absent peristalsis or due to another condition called non-propulsive form. This is also something like absence of peristalsis only. This is because of mesenteric vascular occlusion and pseudo-obstruction. And the detailed discussion about these two things we will have in the appropriate place. Classification due to anatomy. The obstruction can be in the small bowel. Small bowel, again, we have jejunum and ileum. That is why it can be in the jejunum or in the ileum. Then we call it as high obstruction or low obstruction. Then it can be large bowel obstruction. Classification according to nature of presentation. It may be acute, chronic, subacute, or acute and chronic. That means chronic obstruction means already I told you it is large bowel obstruction partial. If this partial large bowel obstruction all of a sudden becomes complete, then we call it as acute and chronic. Then we have subacute. And also we can say acute and subacute. That means previously patient was having subacute obstruction, and on that suddenly there is acute obstruction. Then classification according to the pathological changes. Simple, where the blood supply of the bowels involved is normal or intact, is preserved. That means they are viable. Strangulated, where there is direct interference with the blood flow to the bowels. So whenever there is impaired blood flow, then we call it as strangulated obstruction. When there is no impairment of blood supply, we call it as simple obstruction. Majority of the causes of intestinal obstruction are due to the dynamic obstruction. So let us now study first the dynamic intestinal obstruction. The causes of dynamic obstruction being any tube. When you say obstruction, in the bile ducts also we have studied in the same classification: intraluminal, intramural, extramural. Similarly, we follow the same type of classification here. Intraluminal, that means within the lumen, if something is there, that can cause obstruction. Intraluminal causes: impacted feces, bedridden patients and old people. For the normal colonic movement, there should be normal physical activity. When a person is sedentary, his bowels also will be sedentary. When the person is physically active, the bowels also will be active. So due to old age or due to some disease, if some fellow is bedridden, he is not at all moving, then what happens? All the transit time in the colon is prolonged. That means the motility of colon gets slowed down. So whenever there is slowing of the colonic motility, the stasis of fecal matter in the colon will be for longer period. So when the colon has fecal matter for longer period, it absorbs more water. So when the water is being absorbed, then it becomes hard. So the hardened fecal matter gets impacted. So sometimes, because there is lack of motility or reduced motility, to that there is hardened fecal matter, so the fellow will not be able to evacuate, and that can cause obstruction. So especially in the old people or bedridden people, or who are not doing their physical activity, they are sedentary, this is the most common cause: impacted fecal matter. Then foreign bodies like bezoar, gallstones, ascariasis, food bolus. Normally, whenever a person takes a food bolus, he can swallow only that much amount which his cricopharyngeal junction permits. If its cricopharyngeal junction doesn't permit, then what happens? That will be thrown again into the mouth. The person has to swallow it in small pieces. So, why it is so? If something has passed down the cricopharyngeal sphincter means, then it can pass down safely throughout the guts. That is why God has kept the narrowest portion of the alimentary tract at the forefront. At the beginning of the alimentary tract, He has kept it. That is why if something can pass through cricopharyngeal sphincter means it can pass through the rest of the alimentary tract with ease, without any problem. Then a food which is swallowed, then it got obstructed. It obstructed the bowels. Why? It occurs in gastric bypass cases. We have already seen. in gastrojejunostomy patients, when a person takes high fiber diet or orange with the pith, then that becomes a big food bolus and it's stop at some part of the bowel and causes obstruction. Can you tell me at which place usually the food bolus blocks? Which part of the small bowel usually gets blocked by a food bolus in gastrojejunal anastomosis? Yes. Yes, very good. It is not the ileocecal junction. It is the place in the ileum 60 centimeters proximal to the ileocecal junction. And that is the place where the apex of the midgut loop lies. The midgut is just like U loop in the fetus. And from the apex, the vital intestinal duct goes through the umbilicus. So this place becomes 60 centimeters proximal to the ileocecal junction. And that is the commonest place of obstruction because that is the narrowest point in the small bowel. So when the food is passing through the stomach, bypassing the pylorus, as in gastrectomy cases or gastrojejunostomy cases, then the food bolus can block at this place. Already we have discussed this point when we were studying about the sequelae of gastric operations. Then other foreign body can be due to meconium ileus. Of course, we will study about these various topics, various conditions in the next class, that is tomorrow, under specific diseases. Then intramural causes, that means within the wall. What can block the intestines? Can you tell me? Already we have discussed some intestinal diseases. So what type of intestinal diseases can cause obstruction? Okay, agreed, it is tumor. Other than tumor, anything else is there? Gallstone, it is within the lumen. It is not in the wall. Stricture, very good. Polyp. A small polyp cannot cause obstruction. A large polyp, that too a malignant polyp, can do the obstruction. Intussusception is not within the wall, it is outside the wall. Volvulus is also outside the wall. Yes, stricture due to Crohn's disease, stricture due to tuberculosis, then malignancy, that is lymphoma, carcinoma, they can cause obstruction. So the intramural causes can be due to atresia, then inflammatory strictures like tuberculosis, Crohn's disease, then malignant stricture. The malignancy of the bowel can be due to adenocarcinoma, lymphoma, malignant carcinoid, gist tumors. These are the malignant tumors. So all these things can produce masses or infiltration and they can cause obstruction. Polyps, they are smaller in size, that is why they cannot cause obstruction. Extramural causes, outside the wall. They are intraperitoneal bands and adhesions, hernia, either external hernia or internal hernia. External hernia means which is outside the abdominal wall. If herniation occurs, we call the external hernia. Within the abdominal cavity, if herniation occurs, we call it as internal hernia. Then volvulus, intussusception. These are the extramural causes. Incidence of intestinal obstruction. Inflammatory causes due to strictures, they are about 15%. Obstructed hernia, 12%. Additions, 40%. Miscellaneous, 5%. Pseudo-obstruction, 5%. Fecal impaction, 8%. Carcinoma, 15%. This is the whole population when the incidence was studied. This is the statistics. But if you take old people, it will be something different. If you take newborn, it will be something different. If it young adults, it is different. So age-wise, let's study tomorrow. What will happen if intestinal obstruction occurs? So what is the pathophysiology? There will be changes locally in the bowel due to obstruction, and because of that, there will be systemic changes. So what are the changes in the bowel? You can see here, there is an obstruction in the small bowel. So proximal to the obstruction, there is gross distension. The stomach, duodenum, and jejunum grossly distended. Then distal to the obstruction, what happens? There is collapse of the bowel. The bowel has collapsed. So there will be distal collapse. Why distal collapse? Whenever there is obstruction, the distal part of the bowel goes into peristaltic activity. The normal peristaltic activity evacuates the contents out. Then no more contents are coming. That is why it will be in the collapsed state. There is proximal dilatation. Why this proximal dilatation? I will tell you in the next slide. Then, if it is not relieved, this can progress to, this proximal dilated bowel can progress to strangulation. And if it is due to closed loop obstruction, the changes in the bowel are something different. So we have to study about these pathological changes in the bowel. The proximal dilatation. Following obstruction to the bowel, initially there is hyperperistalsis to overcome the obstruction. Later, in the persistent obstruction, that means even if the peristaltic activity is unable to overcome the obstruction, then what happens? There will be atonic dilatation due to exhaustion. And there will be atonic dilatation without peristalsis. That means there will be atonia of the small bowels. Why the bowels should dilate? Number one, due to gas. Number two, due to fluid accumulation. Why there is gas accumulation? Whenever the person swallows saliva, so normally about 1000 to 1500 ml saliva is secreted per day, and that goes into the stomach. So whenever a person gulps in saliva, along with saliva, the fellow will be swallowing air also. So the air goes into the intestines and it gets partly absorbed and partly it is evacuated in form of flatus. Now there is obstruction. So this swallowed air cannot go down, and it is also not getting absorbed because the bowel is very much dilated and atonic, so it loses its absorptive capacity. Number two, there will be air diffusion from the blood through the devitalized bowel. So whenever there is atonic bowel, then there will be diffusion of gases from the blood into the intestinal lumen. And thirdly, due to decomposition of food products by overgrowth of aerobic and anaerobic bacterial flora. We have already seen in the previous classes, whenever there is stasis, there is proliferation of the bacterial flora. So the anaerobic and aerobic bacterial flora proliferation leads to production of gas. So gas is produced because of these conditions. What is gas made of? Oxygen and carbon dioxide from swallowed air is absorbed into the blood. The remaining gas contains mainly hydrogen sulfide and nitrogen, and partly methane and hydrogen. So these are all the gases due to liberation from the fermented gas, due to fermentation of the food by the microbes. The nitrogen is, of course, from the atmospheric air. Then why there is fluid accumulation? Impaired absorption from the gut, because the gut is very much dilated, atonic, it loses its function. That means loses function means not only motility, its secretion and its absorption are also impaired. So there is sequestration of fluid in the bowel lumen. So where from this fluid comes? The fluid is derived from various alimentary tract juices and swallowed water. So approximate volumes of digestive juices produced by gut in 24 hours. Saliva, it is around 500 ml. Gastric juice, 1000 ml. Bile, 500 ml. Pancreatic juice, 500 ml. Succus intricus, 1000 to 2000 ml. And these figures will vary depending upon fasting food intake. And these values which I have mentioned here are from the recent edition of Bailey and Lowe's Short Practice of Surgery. But those students who are reading my book, Lectures on Surgery, probably there you will find different values. Those values were taken from the previous editions of Bailey and Lowe. So in the previous editions of Bailey and Lowe, the values have been differently given. That's why when I was writing the book, I followed that book and then I mentioned those values there. But of late, when I am going through the recent book, I found that these values have been given differently. Why this difference? So these are the values in the fasting state. Those were the values, that means the higher values were given in my book. Those were the values for a person who is taking the food normally. So in fasting state, naturally, the secretions will be at a lesser rate. So there will be dehydration. Because of the sequestration, this leads to dehydration and electrolyte imbalance. This dehydration is also due to some other factors like reduced intake, vomiting, transduction of fluid from the bowels into the peritoneal cavity, and defective absorption from the bowel. So all these factors contribute for dehydration and electrolyte imbalance. And this dehydration and electrolyte imbalance will be profound in advanced intestinal obstruction. Though there are less number of vomitings, so because the patient has no vomitings, you will be under the impression that the fellow might not have gone into the dehydration. It's not like that. From the beginning of intestinal obstruction, there will be dehydration, either mild or moderate. So, though there is no vomiting, the patient yet can be dehydrated because of sequestration of fluid in the gut lumen and due to impaired absorption of that fluid into the intestinal tract. So please remember that intestinal obstruction produces one of the most important severe systemic change, that is dehydration, hypovolemia, and electrolyte imbalance, and these causes the organ dysfunctions. Of course, we will study about the systemic changes a few minutes later. Strangulation causes compromised blood supply due to rising intraluminal pressure. So the intestinal tube is getting stretched gradually. So what happens? The intestines, they get the blood supply from the mesentery. So the mesentery will be here. The mesenteric blood vessels are coming like this. So this is mesenteric blood vessel. The blood vessel comes like this and divides into two branches. The branches go encircle the bowel. So bowel, when it gets encircled, when the bowel distends, what happens? This encircling vessel gets lengthened. When it's lengthened beyond a critical point, it gets completely occluded. So that is how whenever there is distension, there will be compromised blood supply. This distension is maximum in case of closed loop obstruction. Then this compromised blood supply can be due to external compression of the bowel. If some band or something is obstructing, like hernial orifice is blocking the bowel with the mesentery, then the mesenteric vessels as well as the bowel, they get occluded from blood. So the external compression can be due to hernial orifices, adhesions or bands, volvulus, intussusception, and third cause of strangulation can be due to interruption to the mesenteric flow. For example, the superior mesenteric artery is occluded by a thrombus or an embolus. Then what happens? The blood supply to the whole midgut is occluded. That results in ischemia and gangrene of small bowel or midgut. So that can produce strangulation again. So whenever there is mesenteric ischemia, there is lack of transit. So whenever there is lack of transit, we call it as obstruction. And this obstruction is associated with gangrene of the bowels. So this is a type of strangulated obstruction. So how the strangulation develops? Whenever there is initially the venous return is compromised due to dilated bowel. This results in increase in capillary pressure. This causes local mural distension due to fluid cellular exudation. And this causes compromised arterial blood supply. So initially the veins, because they are thin walled and at low pressure, they get occluded. They produce congestion. The congestion produces edema of the wall. The edema of the wall causes still more stretching. So the still more stretching will cause the compromised arterial supply. The compromised arterial supply leads to hemorrhagic gangrene. And whenever there is gangrene, and there will be impaired vitality of the bowel. So there will be translocation of the intestinal bacteria and the toxins into the peritoneal cavity. This leads to peritonitis and sepsemia. If long segments of strangulated bowel are present, so in these long segments of the bowel, there will be sequestration of blood because veins are blocked, arteries are blocked. So the circulating blood will be completely get sequestrated in that splanchnic vascular segment. This can lead to sequestration of large amount of blood, which can lead to hypovolemia. The hypovolemia due to blood loss. So already we have seen there is hypovolemia due to fluid disturbance. If strangulation occurs, there will be associated sequestration of blood in the splanchnic vascular system. So this leads to again the blood loss, internal blood loss. So there will be fluid loss, there is electrolyte loss, and there is blood loss. So these two complications, that is peritonitis and hypovolemia, are infrequent in strangulated external hernia. In strangulated external hernia, that means when the inguinal hernia, for example, it gets strangulated, the peritonitis and hypovolemia are not present usually, because only small part of the bowel gets involved in that particular incident. So there is lack of this hypovolemia and peritonitis. And the obstructed bowel also is outside the peritoneal cavity. That is why the contents, there is no translocation of the bacteria toxins into the peritoneal cavity. They will be there within the sac only. They are not getting into the peritoneal cavity. So because of the shorter segment and because of the external nature of the hernia, there is no peritonitis, there is no hypovolemia. So this is a case of simple obstruction where there is obstruction with the dilated bowels in the initial stage. If there is a closed loop obstruction, the chances of strangulation are many. That is why this loop undergoes ischemia very quickly if it is a closed loop obstruction, because the distance will be more. And in this twist, the blood vessels are also involved, and that is why they can produce the ischemia. So that is about the strangulated obstruction. Now let us study the pathological features of closed loop obstruction. This closed loop obstruction occurs whenever the bowel is obstructed at both the proximal and distal points. So when the proximal and distal points for a loop, so this is a loop, this is the proximal point and this is the distal point. When both the points are occluded, then it can produce closed loop obstruction. Here, the proximal loop is not distended so much, but the closed loop, that means this loop which is involved, distends enormously. Examples of closed loop obstruction: volvulus, herniation of bowel. So whenever herniation of bowel is there, the neck of the sac, if it constricts, then the whole loop of the bowel will get occluded. Then tight carcinomatous stricture of the colon with a competent ileocecal valve. For example, there is a growth in the transverse colon or hepatic flexure. Ileocecal valve is incompetent. Then what happens? Proximal to the obstruction, there will be dilatation. So proximal to the obstruction, there is dilatation. If the ileocecal valve is incompetent, what will happen? All the accumulated gas and fluid can pass reflux back into the ileum. But it can't go because ileocecal valve is competent. Then what happens? There will be diffusion of gas from the wall. There is production of gas from the anaerobes. So all this gas is accumulating here. So that is causing distension. So this is a closed loop obstruction. So it need not be always in the form of a loop. If the proximal part and distal part of a loop are obstructed, then it produces a closed loop obstruction. So whenever closed loop obstruction is there, what happens? There is stasis. Because of stasis, there is anaerobic bacteria and aerobic bacterial proliferation producing fermentation of the foods. That causes liberation of more gas. That causes distension. The distended bowel loses vitality and there will be diffusion of gas from the venous system into the lumen. So because of these two reasons, there will be gaseous distension. If the gaseous distension increases, that causes impairment of blood supply. And already I told you when I was talking to you in the previous classes, wherever the obstruction in the large intestine, if acute obstruction occurs, the cecum distends to the largest extent. The cecum distends in the beginning itself. So cecum takes the brunt in large bowel obstruction. So because of that, cecum distends enormously, and there will be development of ischemic patches over the cecum. So cecum distends in the beginning, cecum distends to the greatest, and cecum develops gangrene earliest. Even if stricture is there in the sigmoid colon, cecum distends enormously. Why so? So one of your colleagues made this question when I was talking to you in the previous classes. Why cecum distends? Why not the other parts of the intestine? The reason is cecum is the largest part of the colon. Largest means diameter is larger than any other part of the colon. So as per the Laplace law, there is a law in the physics. Probably you must have learned this law in your intermediate. The inward pressure exerted on the wall of a cylinder is inversely proportional to the radius of the cylinder. So I will explain in the biological terms. This is physical term, so I will explain in the biological term. Take the colon as a cylinder. This cylinder is having this wall. The wall of the colon is the wall of the cylinder. Whenever the pressure is exerted inside, for example, there is luminal obstruction here, there is gaseous accumulation, so the gas is pushing the wall. So the wall should distend, but the wall also exerts some pressure. The wall has intrinsic tone, so because of the tone, it exerts some pressure against the intrinsic pressure. When this pressure exerted by the wall becomes weak, then wall distends. So in a cylinder, which is the weakest one? In a cylinder which has the largest diameter, that part has a weakest wall. So that is the law. You can see here, the inward pressure exerted on the wall of a cylinder. So the inward pressure, that means inward pressure is exerted by the wall of the colon here, is inversely proportional to the radius of the cylinder. Larger the radius, lesser the inward pressure. So the inward pressure exerted by the cecum is less when compared to the other parts of the colon. Because it exerts less pressure, it is more vulnerable to stretching. So it stretches. So whenever there is obstruction to the colon at any place, cecum is the earliest one to distend. Cecum distends to a greatest diameter, and because of its greatest distension, it undergoes ischemia and gangrene at the earliest. I hope this point is clear to you now. So these are the local changes in the pathophysiology and pathology of intestinal obstruction. Now let's go to the systemic changes. Reduced oral intake, defective intestinal absorption, and vomiting. Already we have seen. This causes dehydration. Dehydration causes hypovolemia, which produces shock and its sequelae. So there is one doubt from one of our students. Inward pressure, is it due to gas? No, the gas produces outward pressure. So whenever gas is producing outward pressure, the wall resists this outward pressure. How the wall resists outward pressure? By its intrinsic inward pressure. The wall exerts always some intrinsic pressure. That is the tone. The tone of the wall. The tone of the wall is the intrinsic pressure exerted by the wall. So this intrinsic pressure is low in cecum because of the greater diameter. So inward pressure means it is bowel wall's pressure or bowel wall tone. So let's come back to systemic changes. Dehydration produces hypovolemia and shock. Strangulation again produces hypovolemic shock. Distension of the intestines produces abdominal distension and elevation of the diaphragm, and that leads to respiratory embarrassment. There is translocation of bacteria and toxins into the peritoneal cavity, leading to peritonitis, which can lead to sepsemia and toxemia. So there are systemic changes in the form of shock, respiratory embarrassment, sepsemia, and toxemia. So all these things put together will lead to a condition called the MODS, the multiple organ dysfunction. The clinical features of intestinal obstruction. The classical quartet of intestinal obstruction is already we discussed: pain, distension, vomiting, absolute constipation. What do you understand by absolute constipation? What do you understand by absolute constipation? Yes, good. So constipation for feces and flatus is called absolute constipation. And in dynamic obstruction, there is increased bowel sounds. That is barbaricmy. Pain. The character of the pain is it is sudden, severe, and colicky. It is usually placed around the umbilicus in case of small bowel obstruction. In case of hindgut obstruction, it will be in the lower abdomen, that is suprapubic region. The pain coincides with increased peristaltic activity. So whenever the bowel is undergoing dynamic activity, so the pain will be present. Later, the pain becomes constant and diffuse due to distension. So once the dynamic activity is lost and the bowels become atonic, then patients will be experiencing a constant dull aching pain. In strangulation, the pain is severe and constant. Why in strangulation the pain is severe? Because whenever there is gangrene, there will be translation of fluids and toxins into the peritoneal cavity. That peritoneal cavity fluid will cause irritation of the parietal peritoneum. Parietal peritoneum is a somatic structure. So when it gets irritated, that produces severe pain. That is why in strangulation, patients will have first initially at the site of strangulation, later diffusely. Vomiting. As the obstruction progresses, the character of vomitus alters from undigested food to feculent material. Distal the obstruction, longer the interval for the appearance of nausea and vomiting. That means if there is duodenal obstruction, patient presents initially with vomiting. If there is obstruction in the sigmoid colon, vomiting may be a future or may not be a future. Sometimes patients may not have vomiting also. Distension in the small bowel, the distension is central. That means around the umbilicus, and is greater in the distal lesions. So if it is there ileum, obstruction is there, the distension will be more. Gastric obstruction, the distension is less, but vomiting will be more. Distension is associated with visible peristalsis. So you can see the stepladder pattern peristalsis here. In colonic obstruction, the distension is delayed and is peripheral. Centrally, the intestines will be collapsed. Small bowel is collapsed. The distal bowel, that is large intestine, is distended. So it will be peripheral distension. There may be minimal or absent distension in case of mesenteric vascular occlusion. So in any case of intestinal obstruction, you must see the hernial orifices. So you must expose the areas where hernial orifices are present, and you must carefully look for any hernial presence. Any external hernia is there means, and that may be the cause for the intestinal obstruction, and that can be relieved with a simple operation where morbidity and mortality will be very low. Constipation, this may be absolute, there is passage of neither feces nor flatus, or relative, that means where flatus only is passed. So if it is not completely occluded, then patients will be passing little amount of flatus. When there is total obstruction, then patients will not be able to pass the flatus also. So absolute constipation is a cardinal feature of complete intestinal obstruction. Constipation is not present in intestinal obstruction if it is due to Richter's hernia. Already we have discussed about Richter's hernia, that is called partial intrusive. When only part of the wall of a bowel is herniated, then there is no constipation because the bowel lumen is patent. So there is no constipation in these cases. Then gallstone obturation. When gallstone, which is a spherical one, blocks a bowel, then there is no constipation, because what happens is whenever there is obstruction, there will be distension of the bowel. Proximal distension will be there. Because it is a smooth stone, this slips back into the distended bowel. So the obstruction is relieved and fecal matter passes down. So in gallstone obturation, so there is no constipation. Mesenteric vascular occlusion, because there is no luminal obstruction, there will be passage of flatus downwards. And an obstruction associated with pelvic infections, pelvic abscess is there, then in that case what happens is pelvic abscess along with some adhesions that cause obstruction. So adhesions cause obstruction, pelvic abscess causes irritation of the rectum. So because of the irritation, the patient passes quite often mucus in the stools. So he goes frequently to the toilet and says that he is passing stools. When you inquire closely, then that fellow will say there is no fecal matter, but it is all mucus that is coming out. So in pelvic abscess associated obstruction, there will be passage of plenty of mucus per rectum. And in case of partial obstruction, where obstruction is not complete, then also patients will have no constipation. In mesenteric vascular occlusion, there is adynamic obstruction. That means the bowels are not moving. The lumen is open. That is why what happens is the mesenteric vascular occlusion produces gangrene. The gangrene causes bleeding. That is hemorrhagic infarction. Because of the hemorrhagic infarction, there will be bleeding into the lumen. There will be bleeding into the peritoneal cavity. So this blood which is flowing from the gangrenous bowel that will flow down as fecal matter down. Though there is no peristalsis, because of simple pressure, because there is accumulated contents there, the contents will throw the distal ones. That's why they gradually come out and the patient will pass some amount of feces, which is blood. So in mesenteric vascular occlusion also, patient doesn't pass normal quantity of stools and normal flatus. He will pass the bloody stools. So this is what happens in gallstone obturation. So the stone can slip up, relieving the obstruction. This is called the ball valve effect. Ball valve effect. Probably if you must have seen the soda bottles. That means the countryside soda bottles, they have a valve at the neck. So when you just open it down, it goes down and then it relieves the obstruction. Late manifestations. Dehydration lead to hypovolemic shock leading to oliguria. Then pyrexia and sepsemia. Respiratory embarrassment and peritonism. MODS. These are the changes ultimately happen. Just 1 minute. Okay. Next systemic change is the shock. The causes of shock: fluid electrolyte balance, sequestration of blood in the gangrenous bowel, and sepsemia. Why sepsemia? Because of translocation of bacteria into the peritoneal cavity and absorption, producing sepsemia. Pyrexia. Pyrexia in the presence of obstruction indicates the onset of ischemia, intestinal perforation, inflammation associated obstruction. That means some inflammation like pelvic abscess with adhesions is the cause of the obstruction. Hypothermia indicates a severe sepsemic shock. In sepsemic shock, severe condition, there may be hyperthermia, very high thermia, or hypothermia. There may be leukocyte counts increase or it may be grossly decrease. Pulse rate may be having severe tachycardia or it may be bradycardia. So extremes can be seen in case of severe sepsemic shock. Then abdominal tenderness. Usually in intestinal obstruction, when you examine the abdomen, you will notice only distended abdomen. But usually you don't find any local tenderness. Local tenderness will be there in case of strangulated obstruction. So these are the clinical features. Clinical features are mainly, the symptoms are pain, vomiting, distension, constipation. On examination, you will find abdomen is distended, visible peristalsis may be observed, and distension is central in case of small bowel obstruction, peripheral in case of large bowel obstruction. There may be tenderness and guarding if there is strangulation. So those are the clinical signs. Now, how the patient presents to us. So this depends upon the type of obstruction. So the features vary according to the onset of obstruction, acute, subacute, or acute and chronic, the site of the obstruction, jejunal, ileal, or colonic, duration of the obstruction, and the cause of the obstruction. The presence or absence of strangulation. So these factors will cause variation in the clinical manifestations. So clinical manifestation depending upon the onset. Acute obstruction, sudden onset of severe colicky central abdominal pain, distension, early vomiting, and constipation. Chronic obstruction produces pain and constipation. So in chronic obstruction, that means a partial obstruction of the colon. The main feature will be constipation, pain, and later distension. Vomiting may be present or may not be present. And vomiting, even if it is present, it is a very, very late feature. But in acute obstructions, these features are present, all the 4 features are present. A colonic obstruction, partial obstruction becoming acute. There will be history of distension and vomiting in a patient with past history of pain and constipation. So chronic constipation features will be added by the acute features like distension and vomiting. Subacute obstruction, the features will be recurrent attacks of colic relieved by passing flatus or feces. Site of obstruction, how the clinical presentation vary. High small bowel obstruction, that is jejunal obstruction. Vomiting occurs early. So proximal the obstruction, early the vomiting. For example, gastric outlet obstruction, that is pyloric obstruction. Patient will vomit very early. Ileal obstruction, the vomiting occurs few hours later. So vomiting occurs early and is profuse with rapid dehydration in case of the proximal obstruction. Distension is minimal with little evidence of fluid levels on abdominal radiography. Low small bowel obstruction, pain is predominant with central distension. Vomiting is delayed. Large bowel obstruction, constipation is early and pronounced. What will happen in the small bowel obstruction about constipation? For example, jejunal obstruction. So when the jejunum is obstructed, below the jejunum, the ileum, the colon is having the food material, either partly digested or undigested or not digested. So all that gets the normal peristaltic activity and gets discharged out. That means after the obstruction, even though there is obstruction, patient passes stools once or twice. So there is no question of sudden blockage of feces discharge. That means patients do not get constipation all of a sudden. Even though there is obstruction, patient passes fecal matter and flatus for few minutes or at least for 1 or 2 hours after the obstruction. That is why Because the patient is moving the bowels, he is having severe colicky pain in the abdomen and vomitings. That itself are the features of obstruction. Because constipation is not there, you need not go away from the diagnosis of intestinal obstruction. So acute obstruction also can have fecal discharge per annum for once or twice after the obstruction. Then afterwards, there will be absolute constipation. So he passes stools once or twice, then he will get no discharge of fecal matter per annus. But in large bowel obstruction, constipation is early and pronounced. Pain is mild and distension, vomiting and dehydration are late. The proximal colon and cecum are distended on an abdominal radiograph. In all cases of suspected intestinal obstruction, all hernial orifices must be examined. So please imprint this in your brain. Don't forget this. This is very, very important. So it is established case of intestinal obstruction. Is strangulation present or not? The diagnosis is entirely on clinical grounds. There may be features of shock, local tenderness with rigidity or rebound tenderness. So these two features always indicate strangulation. What is rebound tenderness? What do you understand by rebound tenderness? Rigidity means stiffness, something feeling like board. Normally abdominal wall is soft. When you press it, it goes in like this. But when it's stiff, we call it rigid. Then what is rebound tenderness? Do you know the meaning or not? If you don't know it, I will explain rebound tenderness. Yes, you are right. After the hand is lifted off, the patient feels pain. It is done like this. For example, this is abdominal wall. What you do is you apply deep pressure and suddenly leave your hand. Apply deep pressure, suddenly leave your hand. So what happens when you press it down and leave it, the abdominal wall bounces. So because of the movement of the abdominal wall, the internal organs, they get shaken. So the shaken internal organs, they will shake against the peritoneum, parietal peritoneum. So this bouncing of the abdominal wall with your sudden lifting of hand, not just lifting hand, you press it and just take it away suddenly. This will cause bouncing. So this bouncing will cause movement of the bowels inside. This movement of the bowels, they rub against the parietal peritoneum. So when they rub against parietal peritoneum, if they are inflamed, parietal peritoneum is inflamed or bowel wall is inflamed, then patient will get the pain. So that is the basis of the rebound tenderness. If whenever rebound tenderness is present, that always indicates that the underlying part of the bowel is producing parietal peritonitis. Just adjacent to that parietal peritonitis. So you can illustrate the same rebound tenderness sign in acute appendicitis also. So in acute appendicitis also, when you press down your hand down and suddenly lift it in the right iliac fossa, the patient winces with pain. So the same thing is there in strangulation also. This always indicates that this is an early sign of local peritonitis. Why local peritonitis in intestinal obstruction? Because of translocation of bacteria. Why there is translocation of bacteria? Because there is devitalized bowel. In strangulation, there is not only the translocation of the bacteria, but there is also oozing of blood from the gangrenous bowel. Later, there will be generalized tenderness and rigidity. In strangulated external hernia, the lump is tense, tender, irreducible, without the expansile impulse on coughing, with recent increase in size. So, summary of the intestinal obstruction. There are two types, dynamic and adynamic. Causes intraluminal, intramural, and extramural. Affects proximal dilatation, distal collapse, and you will find special changes in closed loop obstruction and strangulation. Clinical features, local features being pain, vomiting, distension, constipation, borborygmy. If strangulation is present, tenderness and guarding and shock will be there. Fluid-related disturbances, shock and MOTS. You can ask me, shock is there even in case of the non-strangulated intestinal obstruction also. Then why are you mentioning shock in strangulated intestinal obstruction specifically? The reason is, in strangulated intestinal obstruction, shock occurs early. Patient gets pain. Within 1 hour, he goes into shock. That means his pulses becomes rapid, thready, blood pressure will be around 70 or 80. So duration is only 1 hour or 2 hours. That means that he is having strangulated bowel obstruction. In case of acute intestinal obstruction without any gangrene, then in that case, the hypovolemia will be seen only after a couple of days, not so early. So if it is occurring within 6 hours after onset of pain, shock is present, means it is an indication that probably the patient must be having the strangulated bowel inside. The investigations. The aim of the investigations, number 1, to diagnose the obstruction. So a patient comes to you with severe colicky abdominal pain or severe abdominal pain. So our intention is, what is the cause for the pain? Is it due to perforated peptic ulcer, acute cholecystitis, acute pancreatitis, or due to acute intestinal obstruction? So our aim is to diagnose whether obstruction is the cause or not. If it is obstruction, then where is the obstruction? Is it in the jejunum, ileum, or in the colon? And third most important thing is whether there is strangulation present or not. So these 3 points we want to study. So the investigations being plain X-ray of the abdomen. This is the most useful investigation and a very simple investigation which is available every part of the country. So this is the most useful investigation to diagnose the obstruction, its site, and sometimes you can say even whether it is early obstruction or late obstruction. Then hematological tests to identify for the systemic changes. What systemic changes we have noted? It can be shock, dehydration, electrolyte disturbances, then pyrexia. So these things you can make out by hematological changes. Yes, I will explain about all this, about plain X-ray abdomen, late or early, all these things I know I am explaining. I will just briefly overview this situation of the investigations. Now I am going into the details of the investigations. Plain X-ray abdomen, you have to take the films in supine and erect posture. Supine means you keep the patient like this, flat, X-ray tube will be from the top. So patient is lying flat, this is supine. Erect means patient will be like this and X-ray tube will be like this. So this is erect. So there are 2 postures. So you take the films in 2 postures. One, keeping the patient in supine position. Number 2, make the patient to stand erect and take the X-ray. What for? Plain X-ray shows gas shadows and air fluid levels. If any radio-opaque foreign bodies blocking the bubble are present means they can be made out on plain X-ray abdomen. Why you want to take erect and supine films? The reason is, now the bubble is like this. This is intestinal obstruction case. So there is a obstruction in the ileum, for example, with grossly distended loops. So the loops are like this. There are multiple loops, and these loops are having air and fluid. Both fluid and air, both are present in these loops. And already we have discussed that air can be seen on the plain X-ray. How do you identify air in the plain X-ray film? How do you identify? How do you identify air in the plain X-ray film? What about others? Others have not responded. Only 3 has mentioned. Yes, the air is shown as a black shadow on the plain X-ray. Then what about fluid? Fluid doesn't show any shadow. X-rays just pass through. You can't see, you can't make out fluid on plain X-ray. You can make out only air or gas in the plain X-ray. So now let us suppose this patient who is having air and fluid in his bowels which are distended. If you ask him to stand, what happens? This is the position. The air goes to the top and fluid collects to the bottom. So now he is having multiple loops. So each loop will have air accumulation above and fluid accumulation below. So this is called air fluid interface. So you will see a black shadow with a horizontal border. Again, a black shadow with horizontal border, and this will have 2 horizontal borders. One border in this loop, another border in this loop. Similarly like this. So like this you will be able to see. For example, the patient has come to you with colicky abdominal pain. You have taken a plain X-ray abdomen in erect posture. These are called the air fluid levels. That fellow is showing only 2 air fluid levels. That is patient A, patient name A. We have another patient, that is B patient. So this patient B, when you have taken the plain X-ray abdomen in erect posture, there are about 10 air fluid levels. In the first one there are only 2, in the latter one there are 10 air fluid levels. So what does it mention? If there are only 2 air fluid levels means it is more proximal obstruction. If there are 10 fluid levels means it is lower obstruction. As you go down lower, more number of loops will be distended and more number of air fluid levels will be seen. If you are more proximal, only 1 or 2 loops are distended. That is why you will see only 1, 2 or 3 air fluid levels. So depending upon the air fluid levels, you can say whether it is a proximal obstruction or distal obstruction. And of course, there is one small fallacy is there in this conclusion. If it is a late obstruction, very progressive obstruction, the proximal loop distends, and that loop has become 3 or 4 or 5 loops on itself. Then you can see more number of air fluid levels. But otherwise, if the fellow has come to you within 24 or 48 hours, you have taken plain X-ray abdomen erect. If there are more than 3 or 4 means it is ileal obstruction. If it is less than 3 or 4 means it is jejunal obstruction. Like that you can conclude. So that is how you say it is the proximal obstruction or distal obstruction. Or similarly, the patient has come to you 3 or 4 days later. There are about more than 10 or 15 air fluid levels. That means his bowels are grossly distended and became too many loops inside the abdominal cavity. So more number of fluid levels indicate either the distal obstruction or a late obstruction. That is how the plain X-ray abdomen will help you to differentiate early and late and proximal and distal. Of course, by simple plain X-ray, you can't judge. You must take the history of the patient also. And you must examine the patient also. Distension, how much is there, peristaltic waves are there or not. So all these factors you must take. Then you can say whether it's early or late or proximal or distal. So this is erect posture X-ray. Patient is standing erect. X-ray tube will be in the front. So when you take the film, then you will get the shadows like this. So because fluid is not seen, only air will be seen like this. So this is called air fluid level. So this is air fluid level. So by this we can say that there is interstitial obstruction. If too many are there, we will say it is more distal obstruction. In supine position, what happens? Let us see. So when the patient lies supine, then what happens? All the fluid filled loops will go to the bottom. You can see these loops. These are clear loops are there. These are all the fluid filled loops. And these black shadows or gray shadow loops are the gas filled loops. So the gas filled loops, they float to the top, and fluid filled loops, they go to the bottom. And when you take the X-ray, so the patient is lying and X-ray tube is on the top, so facing the patient. So all the bowels are distended. So now there are no fluid levels here because fluid filled loops are there to the bottom and air occupies to the top. So you will see only gas shadows, no air fluid levels. So by looking at the border of these gas shadows, you can say whether it is a jejunal shadow, ileal shadow. So this is the what you get on plain X-ray in supine position for the distended loops. Due to proximal distended bowel containing gas, the gas shadows are better seen on a supine film. Why you want to see gas shadows? The gas shadows will tell you about the mucosal pattern of the distended gut, and that will make the diagnosis easier for us whether it's jejunal obstruction or ileal obstruction. I will show you the jejunum. The dilate loops are seen centrally and lie transversely. No gas is seen in the colon in case of jejunal obstruction, and it is characterized by its valvulae conventis, because we have seen in the anatomy of jejunum, the jejunal mucosa is thrown into multiple concentric folds. This is called valvulae conventis, that completely pass across the width of the bowel and are regularly spaced, giving a concertina effect. What is concertina? It is a musical instrument name. This is the jejunal mucosa. You can see here the air shadows or gas shadows of the jejunum. You can see these white lines passing across. So this white lines is the mucous fold, and in between the two mucous folds there is a gas. So this is the gas. So whenever you see such striations in the gas shadow, and the striations, they pass from one border to the other border. They are not interrupted. So there is uninterrupted septae in the gas shadows. So there are multiple gas shadows with multiple septae. So this is a jejunal shadow. I hope you understood. This is jejunal shadow. Again, you can see here, this is the jejunal loops, and you can see these white lines going across in these gas shadows. These are all the folds of the valve, folds of the mucosa. So this is called the concertina effect. This is the musical instrument called concertina. You can see this has these folds like this. So in a similar way, you can notice here the gas shadows in the jejunum. So jejunal gas shadows are identified by concertina effects. Ileum, its mucosa is smooth. That's why it shows a gas shadow which is featureless. So you can see a straight border and there are no septations. You can see here you can see septations, but when you come down, you see the loops of bowel here. They have no striations. The borders are smooth. That means this is an ileal loop. This is an ileal loop. These are the jejunal loops. Then colon. Colon wall has saculations. What do you call that? Those saculations? The Taenia coli produces those saculations. So what do you call those saculations? Yes, very good. They are called as horstrations. So when you look at the horstrations, those horstrations are there on only on one side, or inner side or outer side. Central, there is Taenia coli. So what do you expect the gas shadow? The gas shadow will have septations, but these septations do not pass from one border to the other. They will stop short of the other border. A distended cecum is shown as a rounded gas shadow in the right iliac fossa. Remaining colon shows austral folds, which are spaced irregularly, and the indentations are not placed opposite one another. So this is the colon shadow. There is indentation by a septum, and this doesn't come to the other border. And this indentation is not present opposite this. So they are not opposite to one another, and the indentations doesn't cross to the other side. So these are the hostile shadows. You can see there is septation here. The septation stops here. There is one more septa from this side. So there are multiple septae, but central you can see the air shadow. That means these striations are not passing from one border to the other border. So this is you can see clearly here. This is the hostra. This is the hostra. Central you can see the air shadow. So this is a transverse colon shadow. You can see here, this is another film. This is the cecum. Cecum is showing as a rounded shadow. Valvulosa sigmoid appears as a dilated bowel loop across the center of the abdomen with a septum. This is called coffee bean appearance. The valvulosa sigmoid has a unique appearance. It is a loop, big loop, distended with air. So because it's loop, you can see the septum between the two loops of the bowel. So this is the ascending limb and this is the descending limb. Between the two limbs, you can see a septum. And this is filled with air. So this is valvulus. The diameter of the distended viscus and the site of the viscus is not diagnostic. That means if it is very large distended air shadow, if you see, so don't be under the impression that large air shadows are from the colon. Small diameter air shadows are from small bowel. Don't be under the impression. Once the bowel distends, it can go to any extent. So the diameter is not the criteria to make a diagnosis whether it is jejunal, ileal, or colonic shadow. The diagnosis is made on the pattern that is printed on the gas shadow. Jejunal shadow shows the valvulae conventis or concertina effect. Ileal shadow is smooth without any septae, that is called featureless gas shadow. Colon shows the haustral shadows. Cecum manifests as a rounded shadow. Sigmoid volvulus shows as coffee bean shadow. So if you remember these shadows, it is very easy to make them out on the plain X-ray. So why I am explaining these things in such a great detail is because the plain X-ray abdomens are given for you in the viva voce. So in the viva voce, if you give, surely you will be given an interstitial obstruction case and perforation case. So you must identify gas under the dome of the diaphragm as well as the jejunal, ileal, colonic shadows. And by that you must say whether obstruction is there or not. Number two, whether it is jejunal obstruction, ileal obstruction, or colonic obstruction. How many air fluid levels are there? By that you can say whether it is early case or delayed case, or whether proximal case or distal case. So that is about the supine film. Supine film shows air shadows only. Air fluid, I hope you understood. Of course, about valvular sigmoid, I will give another detailed explanation when we go to the valvular sigmoid topic tomorrow. Tomorrow we are going to discuss about the specific diseases. In that we are going to discuss again about valvulus. Then I will tell you about valvulus X-ray again. The air fluid levels, these are because of the sequestrated fluid in the proximal bowel. They are seen few hours after the onset of obstruction. They are seen only in the erect film. There may be some physiological fluid levels. In infants less than 2 years of age, in the small bowel, you may find 1 or 2 fluid levels. In adults, 2 inconstant fluid levels at the duodenal cap and the terminal ileum may be seen. More fluid levels means it may be an advanced obstruction, or it may be distal obstruction, or it may be adynamic obstruction, that is atonic paralysis. In atonic paralysis, the whole of the small bowel undergoes atony, distended, and fluid sequestration will be there. So there will be more number of fluid levels. So these are the 2 films of a same patient. One film is taken in the supine position, another film is taken in the erect posture. So in the supine film, you can see here, you can see the jejunal loops, and most of them are the ileal loops. You can see this is the ileal loop, this is the ileal loop, this is the ileal loop. Sometimes what happens, one loop will be over the other loop. Then you will not see definitely one loop. So you can see this here, you can see this U shape. That means one loop is overriding over the other loop. And not only about the jejunal and ileal shadows, you must always look for the colonic shadows also. Are there any haustral shadows are seen or not? If haustral shadows are seen, that means that the obstruction is in the large bowel. If haustral shadows are not seen, that means large bowel is empty. So when large bowel is empty means obstruction is proximal to the large bowel. Ileum is distended, large bowel is not distended, or large bowel shadows are not at all seen. So tell me where the obstruction is. So this is the supine film, this is the erect film. Erect film, you can see these are loops with air fluid levels. You can see multiple air fluid levels. By looking at this X-ray, tell me the site of obstruction. Where is the obstruction? Very good. It is at the distal ileum. We can't say specifically whether it is ileocecal junction or at the terminal ileum. That is why we say it is distal ileum. It is not cecum. Don't say cecum. Preferable to say only ileum. Probably it may be at the ileocecal junction or cecal growth may be there blocking the ileocecal wall. But because you are not seeing any hostile shadow or rounded shadow, so don't commit cecum, commit only the ileum. So it is distal ileal obstruction. So again, you can see here, this is a erect posterior film. This is supine film. You are seeing these are the jejunal shadows and ileal shadows. You can see multiple fluid levels, air fluid levels. This is another case where you can see gas shadows. In the pelvis, you can see a rounded density, opacity. That means there is a foreign body. So this is a gallstone. Why I say this is a gallstone? When the same patient's upper abdomen is x-rayed, you can see there are lines of air. So there is a small tubular air shadow here. That means this is air in the biliary tract. Why biliary tract is having air? Normally, if you take a normal person's x-ray, you don't find any air in the biliary tract. If air is present in the biliary tract, means there is some communication with the gut. Normally, papilla of water and sphincter of Wardy are contracted. That's why air cannot pass from the duodenum into the biliary duct. Only bile can pass out from the biliary duct into the duodenum. If that sphincter is cut, as in sphincterotomy operation, then air in the duodenum can go into the bile duct. Or if a stone in the gallbladder enters the duodenum, then also air can enter into the gallbladder through that opening. Normally, gallstone can erode into the duodenum through a cholecystoduodenal fistula. Already we have seen it. So the stone passes down, gets obstructed at the ileum, and that opening is there between the stomach, between the duodenum and gallbladder. Through that opening, the air escapes into the gallbladder. So now you can see air in the gallbladder or air in the bile ducts. So air in the bile ducts, distended bowel loops with air fluid levels, radiopaque density in the pelvis. So all these three put together, they are called the Rigler's triad. Rigler's triad is for gallstone obstruction. So Rigler's triad is the X-ray feature of gallstone obturation. This is the sigmoid volvulus. So when a loop of sigmoid volvulus, so this is the sigmoid, when it undergoes torsion like this. So whenever it undergoes rotation, it becomes like this. So there will be an ascending limb, there will be descending limb. So two limbs will be there. When they grossly distend, they will be one to another. So with intervening septa between them. So what you are seeing here is so this is sigmoid volvulus. There is a twist here. It twisted like this. This is volvulus. There is an ascending limb and there is a descending limb. Two limbs are there. They are grossly distended because it is a closed loop obstruction. When closed loop obstruction is there, when it grossly distends, then what happens? They both will get close to one another. So then what do you see? You see one distended ascending limb, one distended descending limb, and in between you see a septum like this. So that is what you see on the X-ray. So this gives the appearance of a coffee bean or coffee seed. Coffee seed has a hilum in the center. So this is something like coffee seed. Now you can see here, I hope you are able to see the slides also. You can see the slides here. There is a septum in between two loops. This is the ascending limb of the sigmoid. This is the descending limb of the sigmoid. There is a septum in between. When you take this whole thing, it is a oval structure, a oval bean-like structure with central septum. So this is the coffee seed appearance. A barium meal follow-through is contraindicated in the presence of acute obstruction, and it may be life-threatening. I already told you, you should never give barium meal because already there is obstruction. If you give some suspension which is non-absorbable, it goes and precipitates there and increases the obstruction. And it's very difficult for you to take out the barium also. So that's why don't attempt to give barium meal for a patient with obstruction. Instead of barium meal, sometimes you can give water-soluble iodine containing contrast solution. Water-soluble. It is just like water. Barium is barium sulfate suspension. But iodine containing solution is just like water. So if you give that one, you can see these shadows sometimes. If you want, you can even aspirate it if you don't require it. But for barium, it is not possible. That is why barium meal follow-through examination is strictly contraindicated. Barium enema can be given because you are giving barium through the distal limb, distal to the obstruction. So you give barium, study it, and then give a washout. All that barium will come out. So barium enema can be given, but even in that case, if there is a small partial obstruction is there, this barium enema sulfate can go into the partial obstruction and can make it into a complete obstruction. That is why it is preferable to give a water-soluble contrast X-ray. By giving water-soluble contrast X-ray, you can see such type of gross apple core appearance. This is one of our patients. She came with acute on chronic obstruction. She was having constipation for the past 3 or 4 months. All of a sudden, she developed distension and severe pain and constipation, absolute constipation. So I suspected the colonic obstruction. I took a plain X-ray abdomen. It has shown hostile shadows, ileal shadows, jejunal shadows. Because there are hostile shadows, I thought there is obstruction in the colon. So I asked the patient to have the barium enema. So a thin barium enema was given. You can see this is the sigmoid colon, this is the descending colon, this is all the descending colon. Now here you can see a filling defect. And this is second film. Patient was asked to evacuate, and then again a film was taken. So this film shows the same persistent. So that's why when two films show the same defects, we call it as persistent filling defect. The borders you have to see, the borders are irregular. That is why we say persistent filling defect, which is irregular. Now you can see the bowel shadows here, which were not filled with barium. So the imaging studies are mainly for the plain X-ray abdomen, and if you suspect some colonic obstruction, you can go for the barium enema. Hematological examination. If total leukocyte count is more than 15,000 per cubic millimeter, it suggests strangulated obstruction. So whenever there is strangulation, there will be leukocytosis. If you do total leukocyte count for a patient with simple intestinal obstruction, simple means without strangulation, the total count will be normal. The other cardinal features of strangulated obstruction being disproportionate shock, rebound tenderness, bleeding per rectum. CT scan, it is now widely used because it is helpful to make out strangulated obstruction. In strangulated bowel, it may show reduced bowel enhancement, absence of mesenteric fluid helps to rule out strangulation. Of course, these I do not know, I cannot explain you much. Of course, these are also not necessary for you because you should know that CT scan is helpful. That's why I'm showing this slide to you here. The treatment of acute intestinal obstruction. Principles of treatment. Any acute patient, treatment means, first of all, you must resuscitate the patient. Why you want to resuscitate the patient? You must make the patient safe for your surgery. If you operate upon a patient who is hemodynamically unstable, who is having sepsemia, what will happen? You are adding metabolic insult to the patient. With this metabolic insult, the organ dysfunction will become aggravated. Sometimes it can result in death also. That is why you should never operate upon a patient whose metabolic system and organ systems are not functioning up to normal. So you must revive them, then only you must go for surgery. So principles of treatment is resuscitation. So there was a bold statement by Moynihan. I think it is appropriate to mention about that statement here. The statement is, operations are made safe to the patient. So we have devised our techniques, instruments so much that operations are made safe to the patient. Now we must make our patients safe for operation. So operations are made safe by our elders. So those inventors, they made a lot of modifications. They have devised various instruments. They have devised various techniques. So the operations are made safe for the patient. Now, all surgeons, what they should do is, they must make their patients safe for surgery. How they make their patients safe for surgery? They have to bring the metabolic status of the patients to near normalcy. Of course, normalcy is best. If you cannot get normalcy, at least near normalcy. Why I say near normalcy means, for example, intestinal obstruction patient is there. There is obstruction. Patient is continuously vomiting and groaning with pain. He is losing fluids. You are giving fluids. In spite of your fluids, he is still losing fluids, and then there is translation of fluid into the peritoneal cavity. There is sequestration of fluid in the peritoneal cavity. There is sequestration of fluid in the intestinal lumen. So he is getting hypovolemia. So what do? You take a critical point. That means some point where the patients will be stable. Normal blood pressure is 120/80. Pulse rate is 70 to 80. Oxygen saturation is 98 to 100%. You don't wait till all these things are achieved. Even if the BP is 100, pulse rate is 100, saturation is 95 or 96 or 97, you can operate upon the patient because at this stage they can tolerate. Why? Because at 100 millimeters of mercury pressure, there will be sufficient renal blood flow, there will be sufficient hepatic blood flow, there will be sufficient cardiac blood flow. If it is 80, then of course some of the essential organs or vital organs, they do not get sufficient amount of blood supply. There would reduce blood supply. At 100, okay, they can tolerate. So you resuscitate the patient to a certain limit where all his vital organs can function normally. So at that, up to that point, you have to resuscitate the patient. So how you resuscitate? Give fluids and electrolytes. Gastrointestinal suction drainage. You put a Rayleigh tube into the stomach and aspirate all the contents. You can aspirate only stomach contents. You cannot aspirate the intestinal contents. They are mainly responsible for distension. But even some aspiration from the stomach can be helpful to relieve some distension and vomiting. Then next principle is relief of obstruction. The relief of obstruction can be done with conservative management or with surgical management. The first two steps are necessary as preoperative preparation and for postoperative management. That means the IV fluids and aspiration. This is called drip and suction. The drip and suction are essential before surgery, during surgery, and even after surgery also. Conservative management to relieve obstruction. Indications: postoperative or infective adhesions. Worms, that means ascarial worms blocking the bowels. Fecal impaction. So that means a old fellow or a sedentary man comes to you with intestinal obstruction, then that is due to fecal impaction and you can do conservative management. What is conservative management? Drip and suction. Soap water enema. So you can administer enema to clear out all the impacted fecal matter in the colon. So usually one enema may not be sufficient. You may have to give 2 or 3 enemas. But before that, you resuscitate the patient with drip and suction. The soap water enema relieves obstruction in fecal impaction, ascarial obstruction, intestinal obstruction, and it's contraindicated whenever there is tenderness, either more ordinary tenderness or rebound tenderness or guarding. Then suspected gangrene. So suspected gangrene in peritoneus, what will happen? What are the features? There will be guarding, there will be tenderness, there will be rebound tenderness. So when all these three are there, then soap water enema is contraindicated. Preoperative management, again drip and suction, nasogastric decompression, replacement of fluids by Ringer lactate or normal saline, as the losses are mostly of sodium, chloride, and potassium. Blood transfusion if there is evidence of strangulation, because there will be sequestration of large amount of blood in this pancreatic circulation. Monitoring, you have to monitor for shock, you have to monitor for progress of obstruction, you have to monitor for features of strangulation. Preferable to give antibiotics. Why antibiotics? Is it an infective condition? No. Then why do you want to give antibiotics? Tell me. What is the role of antibiotics in this case, in these obstruction cases? It's a non-infective case. Why do you want to? Yes, very good. It is for stasis. Because we have seen that whenever there is stasis, there is proliferation of microbes, and the proliferation of microbes is responsible for production of gas. And the gas is causing a lot of distension. The distension is causing respiratory embarrassment. And the gas and distended bowels will make you give you a lot of trouble when you are closing the abdomen after doing surgery, because bowels are so much distended, so it's very difficult to push them inside and then close the abdomen. That is why it is better to give antibiotics. And of course, antibiotics are definitely indicated in case of strangulation and septicemia. That is okay. Even though there is no septicemia, even though there is no strangulation, even if it's a mild case of simple obstruction, you have to give antibiotics to control the microbial flora, which are proliferating and producing a lot of gas. Then surgery, indications for early operation, obstructed or strangulated external hernia, internal intestinal strangulation. How do you know internal intestinal strangulation? Rebound tenderness, guarding, profound shock. In case of closed loop obstruction, so if you take an X-ray, you see a big loop with the septa, that means it is a closed loop obstruction. Indications for delayed operation, if the obstruction is due to adhesions, where there is not much pain or tenderness. Of course, there is classical clinical advice that sun should not both rise and set on a case of unrelieved intestinal obstruction. That means you have a patient of intestinal obstruction, you tried with drip and suction and IV fluids. Then there is no relief, so you should operate. That means sun should not rise and sun should not set. Then sunrise means it is the morning, sunset means night, evening. So both should not be there on a patient of intestinal obstruction which is unrelieved. That means, in other words, you have to do it as early as possible. Volvulus is a classical example of closed loop obstruction because there are two limbs, afferent limb and efferent limb, and both are blocked by the twist. The twist causes obstruction to both the afferent limb as well as efferent limb. That is why it is a closed loop obstruction. The operative procedure, it depends upon the site and nature of obstruction, the viability of the guts. So you have a patient with intestinal obstruction, you kept the patient on drip and suction. I have given enemas. The patient obstruction is not relieved. Still he is having a lot of pain, distension is increasing, and hemodynamic changes are fast altering. So you are rushing fluids to maintain the blood pressure and pulse rates. So whenever you observe that it is not being relieved, then you plan for surgery. What surgery you do? You do laparotomy. After laparotomy, what do you find? Once you make the incision of the peritoneum, all the distended bowels will come out, will pop out. So they will be there all round. It is very difficult for you to make out where the obstruction is there. That is why what you should do is, first of all, you must go for cecum. How you go for cecum? All the distended bowels are there. You put a mop over the distended bowels. Push them aside. Pass your hand into the right iliac fossa. Deep into the right iliac fossa. You pass your hand and then feel the cecum. Cecum is flattened, is not distant, collapse. Means what? Obstruction is proximal to the cecum. There is no colon obstruction, that you can make it out. The cecum is ballooned out, because in any case of large bowel obstruction, cecum distends. And in the first to distend, it is maximum to distend. So cecum is distended means it is large bowel obstruction. You must follow the large bowel. So first thing what you must do is go for cecum. Cecum is collapse. It is small bowel obstruction. Cecum is distended. It is large bowel obstruction. So if a collapsed cecum is there, then what you should do? You should follow the ileum at the ileocecal junction and just go out, take out the ileal loop and then go like this proximally. That means you are holding this is the collapsed loop. So hold the collapsed loop and follow it proximally. That will lead you to the obstruction. That is how we will go to site of the obstruction. The type of surgical procedure required will depend upon the nature of the cause. You elucidate the cause and treat the cause. Initial decompression of distended bowel helps in surgical procedure and post-operative recovery. So because these large bowel loops which are distended, so if you can decompress them, then that will be better. How do you do decompression? Indications: if the dilatation of bowel loops prevents exposure, if the bowel loops are the viability is compromised because of distension, then you have to relieve the distension. Done with savage decompressor or Riles tube passed through a opening in the bowel guarded by neuromuscular stitch. The simplest thing is you make a small opening, through it you pass the Riles tube and connect the Riles tube with suction apparatus. So you suck out all the fluid and air from the distended bowel loops. Then afterwards take out the Riles tube and close the opening what you have made with a suture. So there are many equipment are there like savage decompressor that is not being used. The simple thing that is being used is just with Riles tube. You make a opening, put a Riles tube, aspirate all the contents. And this deflattening of the distended loop also helps you to relieve the intestinal obstruction in case of the internal herniation. For example, if there is bowels have passed through the foramen of Winslow into the lesser sac, what will happen? The neck of the foramen of Winslow is very much tightened. Very small opening. The bowels have passed through that. Once they pass through into the lesser sac, they distend because the obstruction is there. It is a closed loop obstruction. All the bowel loops which are entered into the lesser sac, now they distend enormously. If you want to pull from this side, you can't pull them out because it is a tight opening and bowels are distended. Then what is the solution? So what you do is you open the lesser sac by lifting the greater curvature of the stomach. Open between greater curvature of the stomach and transverse colon. You cut the greater momentum there, detach greater momentum, lift the greater stomach. Then you see all the large bowels there. So what you do is you put a neuromuscular stitch like this, and the center you put a needle and aspirate all the air, or you put a opening, put a Riles tube and then aspirate, suck out. Then that's how you can deflate them. Once you deflate them, then it's easy to pull out them. A distended bowel through a narrow opening is very difficult to retrieve it out. If adhesions are there, you do adhesiolysis. If any tumor is there, you do excision. Where you can't do anything, you just do bypass. Then you assess and manage viability of the guts. Because we have already seen strangulation can be there. Once you relieve the obstruction, then you look for the viability of the involved bowel. Sometimes they become dark. Bowels become dark. Then you will be in doubt whether they are viable or non-viable. If you keep the non-viable bowel inside the abdomen, they will perforate, produce sepsemia, peritonitis, and death of the patient. So you have to know whether it is viable or non-viable. So for that, what you do is you keep a mop which is soaked in hot saline. So you put that hot mop over the bowel for 10 minutes and you request your anesthetist to give 100% oxygen to the patient. Normally they give only, inspired air has only 20% oxygen. Now you request the anesthetist to give 100% oxygen and reassess. So after 10 minutes, if it is viable, the dark color becomes lighter, mesentery bleeds if pricked, peritoneum looks shiny, interstitial musculature is firm, pressure rings may or may not disappear, peristalsis is observed. When you feel the mesentery, you can feel the normal pulsations. In case of non-viable bowel, persistent dark color, no bleeding if mesentery is pricked, peritoneum is dull and lusterless, intestinal musculature flabby, thin and friable. Pressure rings persist, no peristalsis. Mesenteric pulsations are absent. So by these findings, you conclude that it is non-viable. So when you find it non-viable, the treatment is resection and anastomosis. If the bowel is of doubtful viability, and if you are not dissected, a relook operation should be done 48 hours later. This is resection followed by end-to-end anastomosis. Now I am showing just a small video clip about the intestinal obstruction case due to a band, and now you can see the gangrenous loops in my hand. These are the gangrenous loops. So I am searching for the cause of the site of the obstruction. So a loop of the bowel has become gangrenous. The cause was a band was encircling a loop of the bowel. So you can see this is the place where the band has gone across. You can see this is the place of the band that has produced a constriction ring there. Management of large bowel obstruction, already we have discussed in the previous class. That's why we'll go fast here. If cecum is distended, it is a large bowel obstruction. Just only 5 minutes. I think you have no objection for 5 minutes. If sigmoid is if cecum is distended, then you look for sigmoid. If sigmoid is identified and followed proximally. When a resectable lesion is found in a fit patient, right colon, you do right hemicolectomy. Rest of the colon, resection after decompressing the colon with on-table lavage and prior to proximal colostomy. Or a bypass or a colostomy is done to treat the obstruction, and later resection anastomosis is done. So only for right side colon, you go for right hemicolectomy. For all the other things, for acute obstruction, you do on-table lavage and do resection anastomosis. If on-table lavage is not available, you do a bypass operation. Or you just do proximal colostomy and leave it like that. Once the patient condition improves, then you reopen the abdomen and do the resection anastomosis at a later date. Recently, self-expanding metallic stents are being placed to relieve the obstruction caused by tumor. So in acute obstruction, what you can do is you can pass a stent like this along with, so this is the endoscope. A guide wire is passed. Over the guide wire, a metal stent is passed and it is pulled into the stricturous area, and later a balloon is passed and it gets dilated. So this metal stent will be there in this place. Once it gets expanded, it remains like that expanded. This is on-table lavage, already I have explained to you. Of course, operable carcinomas, right side right hemicolectomy, hepatic flexure, extended right hemicolectomy, transverse colon, transverse colectomy, splenic flexure and descending colon, left hemicolectomy, sigmoid colon, sigmoid colectomy. Of course, I already told you about the rationale and principles of the colonic cancer surgery. If the lesion is irremovable or patient is not fit, you do a bypass operation like iliotransverse colostomy or transverse pelvic colostomy, or you can do colostomy, cecostomy, or ileostomy if the ileocecal valve is incompetent. This is iliotransverse colostomy for a right colon growth in an unfit patient or where it is inoperable. This is transverse pelvic anastomosis. This is descending colostomy for a rectal cancer. For hepatic flexure growth, if the patient is not fit for iliotransverse colostomy, you can do a cecostomy or ileostomy. Of course, these are the colostomies. If the growth is operable, but the patient is not fit, you do Paul McClick's operation with resection of the growth, or Hartmann's operation, or colostomy with mucous fistula. This is called Paul McClick's operation. So, for example, a volvulus is there, a gangrenous volvulus, or a tumor is there, where tumor is resectable, but patient is not fit for resection and to anastomosis. Then what you do is, you make a opening in the left iliac fossa, get the colon bearing the tumor outside, and the ascending and descending limbs are sutured together to make them a double barrel structure. Then you excise them and make it as a colostomy. So this colostomy is having two openings. Then afterwards what you do is, if the patient condition becomes okay, then what you do is, you pass this instrument called enterotome. You can see here, this is having two strong stout blades. So one blade is passed into one limb, the other blade is passed into the other limb. Then both of them are approximated and they get tightened with the help of a screw here. Daily you tighten it gradually, daily 1 or 2 turns. So with what happens, this screw, when you are tightening, these two blades, they come together very close. In between them, the septum gets crushed away. So the septum crushes and then it gets open. So once it gets open, then you take away this colostomy, cut this away, suture it and push it inside. That means without reopening the abdomen, just by doing something here, you can again close this colostomy. So this is called Paul McClick's colostomy. This is the fourth Hartmann's operation. You remove the tumor and bring it out as colostomy. This is immediate resistant mucous fistula formation. So this is how you manage the colon cancer. Already we discussed it, just that is why I am just touching briefly about the points. So this is in general the management of intestinal obstruction. Tomorrow we will discuss about specific diseases causing intestinal obstruction and their management. If you have no more doubts, I will close this session and we will meet again tomorrow at the same time. Any doubts, please? Okay. Thank you. Wish you all good night. See you tomorrow at 4 p.m.